Hi, it's Matthew Holt. It is August the 18th, 2022, and you're in episode 101, hopefully not the room 101 of, of 1984 fame, episode of THCB Gang. My torture companions today are Mike Magee, medical historian, Kim Bellard, regular writer and contributor to THCB, Vince Kuraitis, these days self-start platform analyst and expert, but has been doing a lot of work on that, and Michael Millenson, all-around wit, president health quality advisors. So we're going to have a bit of a fun discussion about some stuff that has happened, and a lot has happened, right? Notably, one of the biggest bills ever signed, which had a bunch of healthcare stuff in it and a bunch of non-healthcare stuff in it, has been signed, and a bunch of other stuff in the private and public markets. So we're all right in the dog days of summer. I don't know how many of you have been, we even have heat in Northern California, but it's probably much hotter where most of you are. And nonetheless, stuff is happening. So with that, why don't I ask everyone to tell me what they've been up to, and I'll kick it off with Michael Millenson. I can't even do the Mike M thing here.
Well, as you said, this was the week that was. We have the bill signed by Biden, which has the Medicare drug price negotiations, which the drug companies said would lead to sick people begging in the streets for cures. And yet after it passes, the security analyst says won't affect their profits at all. We have control on the price of insulin, which the drug companies did not invent. We have an unheard of event, which is the Wall Street Journal having an editorial in favor of the Biden administration for having over-the-counter hearing aids. And we have the Obamacare subsidies being extended, which will bring the Democrats no political benefits at all, because the people getting the money, the white working class folks, have no idea it comes from Obamacare. And finally, we have the CDC being reorganized, which I believe involves the head of the CDC, Dr. Walensky, telling the bureaucrats a pox on all of you. So nothing much happening this week. I was reminded, though, of the Catholic Church sex scandals when the Walgreens, CVS, and Walmart received $650 million fine for opioids, which is, if you're big enough and respected enough, no matter what you do, it ain't going to affect things. You're still going to persist. So our friends, the large pharmacy companies, can shell out a little bit of money, which is probably covered by their insurance policy. And really, the evil that men do lives after them. The good is often turned in their souls, and they'll just keep on keeping on.
We don't often get theological here on the THCB Gang now. Kim, what have you been seeing?
Well, I think Michael just did the whole show. We can just stop right now because he's covered the water.
We should all quit and be done. It's 3 minutes in. We're over. It was nice. Nah, come on. You don't go
touch upon two of the things he mentioned that, you talked about the drug companies. So a Reuters report said that the average price of new drugs in 2022 is over $200,000 per drug. So, wow. I don't weep for them about the insulin and the drug pricing on the 10 drugs that Medicare is going to start with. The other one I want to touch on is the FTC over-the-counter ruling. So I thought I vaguely remembered writing about this. I went back. I wrote about this in 2018 because the law that allowed it was passed in 2017. And in 2018, the FTC said they were going to issue rules on this in 2020. So here we are in 2022. And, maybe it's going to start in October. So like they've managed to, the people that are opposed to this, the audiologists and the hearing aid people, have managed to drag this out for 5 years and costing people an amount of things. That being said, it's a great thing. Most people don't need the prescription. Most people can do pretty well. A lot of people are now going to hearing aids. They're not called hearing aids, but do a good job anyway. So I'm hoping that this is a breakthrough that, we're going to get to start to see more direct to consumers, cheaper technology that's going to help a lot of people without going through the medical system.
Yeah, actually, and I talked to Charlotte Yeh a while back, who's the medical director of AARP. And Charlotte's, I said to her, what's the biggest thing we're not talking about? She said hearing is like, hearing and hearing loss and lack of easy access to cheap hearing aids is one of the biggest problems for older Americans. And, we're all wearing our glasses, and I buy my cheap Chinese, $3 a time glasses that I lose everywhere. And I think, maybe hearing aids start becoming, I'm not going to be, they're more sophisticated, but maybe they're going to come down into, we'll have the electronics revolution will hit them in a way that'll be good for consumers too. And I think as you see the world getting older, right, this is not just an American problem. This is going to be worldwide with the need to improve that. Mike, what have you been up to? What have you been looking at? Unmute yourself, Mike.
You're muted, Mike.
Oh, we'll go to Vince. There you are. All right, come back, Mike. Come back to us.
I'm not a pro at this,
You've only wanted this show about 50 times. Come on.
Like many of you, I've had some experience both writing about and experiencing long-term care settings. And my wife's brother, he's one of 10, developed progressive supranuclear palsy and came to live with us to care for him about 1.5 years ago, and was in a long-term care facility in town. And yesterday he died peacefully. And what we got to experience is obviously all the ups and downs of long-term care. And they've had a lot of, challenges, special challenges over the last couple of years between COVID, staffing shortages, and low pay, and a lot of difficulties where, you might come in any one day and question people's humanity. But when we arrived yesterday morning to say goodbye after we got a call that he had died peacefully in his sleep, the image that struck me were the people that my wife had so carefully and appropriately provided oversight to, and thousands of suggestions and encouragements and complaints from time to time. Those people were lined up, and one by one, they were quietly going in and saying their own goodbyes to him. And I think that was an expression not only of the fact that he was kind of a Christ-like figure who could take his suffering and never become bitter, and always manage to still raise one hand and give a gentle wave to people who went by, or grab your hand to let you know that even though he couldn't speak or see you, he knew you were there. He appreciated you were there. But it also, I think, spoke to their humanity. And I think for a lot of families who are in this situation, they come in and they see people who are doing a very difficult job and seem to be closed down and seem to be harsh or seem to be not interested, when in fact, these people labor in situations that place them in some psychological harm. And it takes a lot of strength to do jobs which you're not paid well for, paid terrible for, and jobs that are very physically and emotionally draining. And yet, these people demonstrate again and again that they got big souls, big hearts. And I just thought it was interesting to see how moved they were. I mean, he clearly needed to die for him, for everyone who was caring for him. And yet when he was gone, they were saddened. So anyhow, it was instructive.
Sorry for your loss, Mike.
Sorry for your loss, and sorry for your wife's loss. And it sounds like it was a dignified end. And I think you're raising a really interesting point. I saw a tweet from this is from Hallie Tecco, who some of you know has founded Rock Health and is now a sort of investor and an entrepreneur in digital health, about her mother, who is, and I know Hallie decently well, but didn't know about her family situation here. Her mother is in her 70s, working for attendant healthcare, has worked through them all through the pandemic, and asked for a pay rise from $17 an hour and was turned down. And that was quite, I think, and that probably is, similar to some of the situations, many of the people who we're talking about, who are caring for your brother and working long-term care, and obviously working at-home care. And, we've talked many times on this show about the labor shortage. And this morning, there was an announcement that yet another of the nurse staffing agencies raised $1 gazillion. This one's called Incredible Health, from a very, very smart British surgeon called Dr. Azabid. And she's got a great team, and apparently it's worth $1.5 billion, $1.6 billion, and the rest of it. But, it's still a question of, and we know some nurses at hospitals are not getting very well paid, but the sort of inequity of income for caring labor, all the way down to the unpaid caregivers. We don't have Alex Drain on the show today, but all the discussion about unpaid caregiving, we know is still an amazing feature of American healthcare that we have really not got to see. And yes, the other thing we know is that caregiving of any description, is something that's very, very hard and is very emotional, has very big emotional impact. And you obviously saw that today or yesterday, Mike, or today, this morning. Fantastic. All right, Vince, you've been platforming away. So a platform. What have you been up to?
What caught my attention this week was an article in Fierce Healthcare, and I'm going to read you a few numbers. They may shock you, but not for the reasons that we usually think. They were reports on the operating performance on 4 very large health systems. Providence, which is Northwestern concentrated health system. These were second quarter, so it's just one quarter, and their operating losses, $424 million operating loss. Kaiser Permanente, $1.3 billion operating loss. Sutter Health, $457 million. Mass General, $949 million. And there's also a quote of the investment income losses for Providence, $920 million lost on their investment portfolio. Wouldn't it be nice to have an investment portfolio where you would actually lose $920 million?
Were they shorting Bed Bath and Beyond? Is that what they were
So I don't know if these are representative. I'm hoping to tap the wisdom of the group, but it shocked me, frankly, because all we've been seeing is how much money large health systems have been socking away. And even throughout the pandemic, where we've seen this kind of K-shaped recovery where rural hospitals have really suffered. A couple of footnotes about why for Providence. Of their $424 million loss, about 40% of that was for extended personnel costs or raises or having, again, just the fact that it's hard to get people. And they also attributed a several percentage decline in operations and surgeries. So I'm curious whether anyone can shed other light on this. This has kind of changed my conventional wisdom of the financial success of large health systems in the recent future. But that's what caught my attention this week.
Yeah. So ours can weigh in, but clearly we've seen in public companies, right? HCA and both Tenet I just mentioned, the ones who wouldn't give Valley Takeover's mom a pay rise, have both seen similar losses in the first quarter, and that's looked like the big non-profits are carrying this over to the second quarter, and a lot of it has to do with having to pay staff a lot more because the labor shortage is still as bad as it was, and there's no CARES Act to help them out this time, and also
no CARES Act.
The stock market is not being as friendly. Having said, I'm crying. Yeah, I'm with you. I'm crying about they lost $900 million in the stock market or whatever, but how much what they made, like $8 billion or something the previous 2 years.
Right. It's the question is that, like, in context, right? So if you lost $1 billion on your investment portfolio after the previous years making $2 billion, right? I mean, it's just to look at Mass General and those people up there, right? I mean, they've often had a license to print money, and while you're sorry they've lost money in a quarter, you kind of wonder about the perspective. The other thing that I'm trying to get my mind about around this on labor. Maybe you folks have an idea. We know that these travel nurses and the rest are really expensive, right? And we also know that when the regular nurses see that these travel nurses are coming in, we're earning more money than they are. Those of the regular nurses often have the flexibility because they can move around and the kids are growing or whatever. Often, quit and become travel nurses. So you end up with this bad cycle. If hospitals had been paying nurses better to begin with, which we go through this cycle, though it's a shortage, not, if they had been paying them better to begin with, would they have avoided this crisis? I mean, were they penny wise and pound foolish, or penny wise, as it were, with look at all the money we saved the years we didn't pay them, now we have 1 year where we lose money? I mean, I don't understand the economics of how hospitals pay for nurses and other personnel that we now have shortages of, whether or not they made a decision that is coming back to bite them or not. Maybe you all have an idea.
Yeah, my take, and it's more anecdotal, is that there's a lot of positions in hospitals that are viewed as being pretty well paid compared to other payment alternatives. I think the other factor that's at least worth mentioning is just the burnout factor caused by COVID over the past 2 years. And how do you keep up with that? I mean, anyone who's been paying close to minimum wage has seen their workforce walk out the door. So yet we have full, pretty much the same level of employment that we had prior to
Could
COVID.
they have avoided this then, Vince? I mean, if I agree with you completely and say, okay, the burnout, had nurses been more well compensated even before COVID, had there been a little bit more compassion about what they went through? I mean, I don't see a lot of turnover in chief financial officers, right? Or they're not getting it. There's no traveling CFOs going around. So I'm just wondering whether or not this was unavoidable, or whether, this was some policies that maybe were short-sighted.
Well, I mean, let me pile in on one more thing here, because there's been there's talk about staffing problems, staffing shortages. The most notable one from where I live, and this has gone on for years, has been the lack of mental health counselors, social workers, psychotherapists for Kaiser Permanente, particularly in California, right? They're one of the main companies you mentioned, also a company which I forget the number, but it's like 40 odd billion a ridiculous amount of reserves. They would be a mega sized hedge fund in terms of how much money Kaiser has stashed away. Has its own medical school now, among other things, but has been unable to figure out how to supply adequately. It's both the states come after them for this, and their own staff are on strike again. I mean, they literally walked out today, or yesterday was an NPR article about the fact that, a typical person with mental illness who has urgent needs, is on a waiting list for 6 to 8 to 12 plus weeks to get access to care. And, it seems to me that the staffing issue could have somehow been resolved. And yes, we've all talked about physician staffing over the years, and how much we should pay for resident, how much Medicare should pay to subsidize residency spaces, and are there too many doctors? Are there not enough doctors? Are there the wrong kind of doctors? Which is probably the real issue on the physician side. But in all the other staff, nursing, social workers, therapists of the hundreds of types, where there seems to be, a shortage, you'd think that the system could have kind of come together and figured this out some time ago. And, maybe there is going to be some effort towards this, but it seems to me as though when you've got a situation where, whether it's social workers, psychotherapists, or nurses or whomever, where it's so desperate that venture capitalists are better invest hundreds of millions of dollars in multiple different, essentially new staffing agencies, that we've got a bigger societal problem here, right? And that's an area where we should be investing. And I don't know, I don't recall if in one of the versions of the Build Back Better infrastructure, whatever bill we've got, there was going to be a bunch of training, there was going to be a bunch of stuff for our care at home. I don't recall if buried in that there was going to be, and I know it didn't make it because, as Joe mentioned, there was going to be some more money for training. I think there is a bunch of money, by the way, in the energy, although the renewable energy part of the bill, for it's not so much training, but if you are going to manufacture new renewable energy, you have to take on unionized workers, and you have to take on apprentices. And I know something like that, was going to happen or could happen, but in such a huge sector, we've got to surely come up with an approach where either we're not depending on these big systems to lose $1 gazillion because because they can't get it right. But we also aren't burning out the current supply of nurses who, as we, and other healthcare workers, who, as we know, are much older than average workers, and we're not attracting enough younger workers into that area as a whole. So,
I wrote about a related thing last week. So, Vince, Mike mentioned the long-term care workers and certainly the home care workers. But if you look at teachers, nurses, childcare workers, they're all in short supply. They're all underpaid, and they're mostly all women. So and I think that's same true with the long-term care workers. So it does seem that there's a bias going on here about pay and what we value, and it does seem to be very gender oriented, and so we need to be thinking about this. And it's kind of odd saying this on an all male panel, but nonetheless.
Are things better in the UK? Is it managed better?
So I think that I don't know enough to be clear. The UK health service is permanently under stress. All the nurses are public employees. So there's a bunch of areas where that this gets very politicized and it's more unionized. This gets much more politicized in the UK, and the NHS is currently being asked to spend to do more with less and all that kind of stuff. My impression is that there are countries where certain of these professions are valued much more. My impression, and I don't know a lot about this. My impression is if you go to Finland or you go to Germany, school teachers, for example, are much higher paid and probably more respected than they are here. And we clearly, if you go around, there are some women who make lots of money in America. One of them just resigned. One of them has just resigned her job as the leading tennis player in the world for the last few years, and is going to become a venture capitalist instead. So, I don't think Serena Williams is typical, but clearly we have some structural sexist, racist, whatever you want to call them, issues about who are doing these jobs. And you'd think the only way that can be turned away in two ways, right? One is government reallocation of resources and wages, and obviously most school teachers are public employees, and people are prepared to pay more tax for that. And the other thing is, could the big health systems, the ones who are losing this money, do something upstream rather than basically relying on what's been going on the last few years, which is stealing from each other, which is what the travel nurse thing is, and this money going into these new agencies. So I don't think any of us are experts on the sort of labor supply for these issues, but I did have dinner last night. It was a very bizarre dinner I was invited to with a bunch of Australian public sector officials and a few consultants wandering around. And I met a labor expert, actually an American labor expert who'd done some work with Amazon. And she told me something which was quite amusing, which was that she got recruited by the real high ups, the Bezos level at Amazon, to try and come to Amazon to use. She had an amazing background, AI skills and all kinds of other stuff, to improve their people's experience. And she said, "I'll do it for free so long as you let me do what I think is right, and you don't object to the unions." And they never called her back. So we have that kind of thing going on. And I have a friend who's just left Kaiser, and he said he didn't want to deal with the fact that he knows there's going to be a big union dispute coming up later this year between Kaiser and its nurses. So somehow we haven't got this right. I don't know what the answer is, but somehow this is an area, and it's the first time we've always heard about nursing shortages and doctor shortages. It's the first time I recall the actual cost of nursing because of the labor shortage actually showing up and really bashing the bottom lines that Vince just came up with.
Well, I'll be curious to know whether those numbers continue in the third quarter. I mean, everybody took a hit in the investments in the second quarter.
Exactly.
So the market's up pretty well this quarter. Is it a structural thing, or is it just a short-term cycle thing? That's what we don't know yet.
Well, but you have to separate just on that point. I mean, that's the other joke, right? So they have to report mark to market. So when they report, it's kind of stupid because they report their mark to market investment portfolio as well as their operating income or loss, and you have to separate those two out. They don't in general do a good job of reporting that, and the press doesn't do a good job of saying that, because for all intents and purposes the investment income and the reserves are sitting there on their own. I mean, as far as I can tell, they never use them for anything. They didn't use them. That's not entirely true, but they were happy to accept. Most of these organizations were happy to accept government money when the CARES Act when buff came tough, even though the amount that they needed was much less than most of them had, sitting in the reserves in their bank and their hedge fund. But I think the question you're asking, Kim, is on the operating side, are they going to figure this out, right? Are they going to figure a way to bump up volume and surgery and what have you? Are they going to be able to figure out a way to is the nurse cost going to come down? Is the excesses of the sort of traveling nurses, they're going to sort that out? And they're going to get back to normalcy? And my guess is they probably will, because hospital operators tend to do that kind of stuff.
So I'd like to float a hypothesis out there. I spent 10 years working in an integrated delivery system, and what we experienced was what we called death by 1,000 cuts. That all of the insiders of a local delivery system began to become competitors. The doctors started their own surgery center. Another company came out. We had a group of nephrologists that were approached by a for-profit company. And today's analog that I am thinking about or seeing is, it's not death by just 1,000 cuts, it's death by 10,000 cuts, where you add all these digital competitors. You think about all these different companies that have been funded to care for niche patients. And collectively, are they beginning to have an impact upon the delivery system? Companies that focus on particular diseases or particular parts of the body, or a particular race, or men or women, or LGBTQ populations or older populations. That's my theory of a death by 10,000 cuts. It's tough it's really tough, sitting in the chair of, working around strategy in a health system, because you got so many people coming after you.
I'm always wondering about this, and I'll go to Mike and Michael and Mike in a second. But just yesterday, I did an interview on THCB with Lyle Berkowitz, one of your fellow Chicagoans, Michael. And some of you may know Lyle. He's the he's been around about a lot. Ran the research institute at Northwestern, and there's a lot of stuff in health IT over the years. He's just done a startup, right? Literally just launched this new startup, and the startup is a virtual medical group which is doing after hours, out of state, and surround care for big health systems. He's got Spectrum in Michigan on the go, and he will be adding to others. And they're using Epic because their installation of Epic can mesh with others. They can set appointments into the system. And they're basically, as far as I can see, this thing called KeyCare, sort of helping the health systems play defense against leakage out of the system to all the people you're talking about.
Right, and, exactly.
They're not going to. I know the story you're telling, Vince, has been around a while, and most health systems haven't sat there and took it lying down. A lot of them went out and bought a lot of those players, or merged with them, or if there was an urgent care center, they built their own urgent care centers, and they're very keen to keep people flowing in. And we know that of the primary care doctors they bought, they lose money on each one because they make so much more on the referrals back into the big white building that it's worth them doing that. And over the years they've done fine. So yeah, maybe I've been sitting around for 30 years saying, well, this can't last,
But the part about death by 10,000 cuts is it's hard to attribute to any individual cut. I mean, you just add to the list the competition from Amazon One. I suspect we're going to see a lot more acquisitions of individual groups. Optum now is the largest employer of physicians in the country. They employ 60,000 doctors, and those doctors are not being trained in filling up the surgical suite of the hospital.
Sorry, some of that, Mike.
Mike, you're muted, Mike.
Yeah, that we all need hearing aids.
Well, that's it. The hearing aids.
Yeah.
I'll be sending out the THCB hearing aids for the next round when they come down to the $3 rate.
Here's my point of view. Even if we had enough money infused in the system right now, I think we've taken a really destructive left turn in the way that we've structurally organized at least outpatient care. The way it is structured, at least in the integrated system that I'm in, and I've been familiar with a couple of them where, you had a tertiary center, the tertiary center then saw its geographic area and decided to plant outpatient facilities. They bought up a lot of doctors. They bought up a few small hospitals. They created an integrated healthcare system. The way they structured up most of them that I'm aware of, their ambulatory care is that they put in extensive obstructive telephone trees and totally centralized, I guess for cost purposes, their scheduling. And in the process, the primary care doctors they did have basically became purveyors of the annual Medicare examination. So in terms of real life people who need to be seen when they have a problem, there was zero capacity to accommodate people who were worried or fearful or got into trouble and needed emergent evaluation. And since their primary care guys routinely, if you got into these telephone trees, they'd say, well, we're booking 4 months out. But, you can go to urgent care. It's connected right next door. Or if you want to come in and see a PA, they are available. The primary care doctors, in turn, were in the back checking their MyChart messages, or more likely their nurses were checking their MyChart messages. So even me as a physician could not penetrate these people. There was no such thing as professional courtesy anymore. In fact, there wasn't anything even close to it, because what you got instead was rudeness. And rudeness, even though they knew you were a fellow doctor, the whole system was designed to not allow you to penetrate. Now, this is under the rubric somehow of primary care continuity. And as I said to my wife, I've sort of given up on that, because I can't even talk to my primary care. I can't even get, 2 levels removed from my primary care, let alone get a referral. And so I'll just try to collect my own group of specialists and see if I can be the person who's doing the continuity. And I know the system. I mean, I'm well educated to the system. So from the standpoint of everyday people, they are not being served. They're just not being served, even though we talk a good game around primary care continuity. Now, in contrast, my oldest boy, who has MS, and his wife was a doctor, and he's pretty familiar with the healthcare system. So he's no neophyte for sure, and has done well over the years, managed by a neurologist in Providence. His primary care setup there has no scheduled day-to-day hours. It's like when my father had the office attached to the house. If you have an acute problem, you come in, you sit in the queue line. If there's not a long queue line, you get seen pretty quick. If there is, you got to wait a little bit. But the primary care doctors are actually caring for people day to day who need help, which is kind of the whole idea, right? The whole idea is not about an annual planning meeting where you check off all the boxes and you get paid, and somehow we think that the health of America has improved as a result. What makes people feel healthy is if they're not scared shitless, and if they feel like somebody's there if they're in trouble, and when there's a responsive organization in their neighborhood. That's what makes people feel safe and cared for. And the rest of this is bullshit. And so I'm kind of fed up with the whole way this thing has been organized. Because if I was still in the management business and I was doing outpatient care, the first thing I'd say is, can a patient who's scared and feels they need help today be seen 7 out of 10 times by a doctor who knows them? If not, I'd say, well, where the hell is that doctor? Is that doctor away? Is that doctor on vacation? If that doctor is just checking off boxes for a Medicare annual visit, I'd say get the PA or the nurse practitioner to do that, or get the nurse that's, taking the MyChart messages to do that. So I think it's a total misappropriation of the talent. The talent of a doctor is to process fear and worry and recognize if there's something acute that needs to be dealt with. That's their skill. If any of the training is worth it, that's what they ought to come out with, not the ability to do long-term planning about health prevention. I can get a computer to check off those boxes. So I'm just fed up with the way integrated health systems have decided to use the doctors that they got to agree to be employees. And I'm upset very much with the fact that the doctors seem to have accepted it, that they collect their paycheck and they don't see any patients. So that's my say.
Did you see the article in The Lancet that estimated that for primary care doctors to do their jobs right, they need 27 hours a day?
Sounds reasonable to me.
But look how they're using their extenders. They're using their extenders to see the patients and using themselves for all this back office stuff. It's ridiculous. I agree they're asked to do too much, but that's in part because they're doing the wrong things.
Mike, I agree. I talked the other day with some friends who couldn't get their son in to see anybody for, they would only be seen by a PA, even though he had some ongoing issues, couldn't get a primary care doctor. One of the things I've been thinking a lot about is the splintering of the American healthcare system, right? With the kind of competitors that Vince is talking about, and with a lot of the different niches taken and all the rest of that. And then the response of the conventional healthcare system, which is often exactly what you're talking about, the sort of short-sighted management things where they put the primary care doctors into a processing mode where they can get paid really well for Medicare wellness visits, right, which pay really well. And then you stick everybody, you want to see a doctor, we have the immediate care center with the new doctor who you've never seen before and just graduated from medical school. And then we take that excess money and we invest it in niche companies or our venture capital fund or whatever. And I wish the doctors were more organized in trying to reclaim the kind of professionalism you're talking about, as opposed to a lot of them either vigorously campaigning for a return to the past that never was, like the AMA does, or trying to get a piece of the action by going to work for those companies and trying to splinter everything anymore. And the kind of in between that you're talking about, practice medicine in the 21st century, but practice it with certain old-fashioned values, is in some ways getting, passed over. And when I hear some of what we're talking about, it reminds me again, the decline of the American automobile industry was not because of the American worker, as much as some people used to bitch about that, because when Honda came in and made cars in Maryville, Ohio, and Toyota came in, right, the cars were just as high quality. It was a decline of management vision and management ability that did it. And maybe some of our integrated healthcare systems are a lot of Me Too strategies, doing exactly, Mike, what you talked about. And there's too few of them who are run by people with real vision and real commitment. And instead they're chasing short-term stuff that they think is what they need. And they really don't have the vision to stop the decline in the American healthcare system. It ain't the doctors who are at fault, although they are as a profession. It's, who are the people who are managing it? And it's concerning. Just a last note, it would be interesting, Vince, to take your hypothesis and look at a system that makes oodles of money and now has a loss and see whether that was. My guess is that some of the really big systems that we're talking about made their money off of investments and then lost their money off of investments, and compensate some by raising prices, as we've seen some of them have raised prices. Do they do efficiency? Do they really know whether or not, those ads for Hims are taking away appointments from the urologist that they used to make money off of? I doubt it, but it would be interesting to see whether or not their profits are being affected, or whether it's just a matter of how well they manage, the usual things. But I think I agree with Mike. I'm concerned about how we're changing American medicine thoughtlessly.
I'd like to push back on your automobile example for a second. So certainly the management was in many parts responsible, but so were the workers, in terms of the unions were putting on very restrictive rules, asking for a very high compensation, asking for a very large benefits. When Honda and Toyota came in, they didn't have unions. So
that's fair enough. The unions and the management together were engaged in a dance of endless profit. Fortunately, nobody in American healthcare acts that way.
Yeah, I think the analogy is that we both have fossilized workflow processes that are not resulting in the best quality or the best cost, and that's the analogy. And at some point, healthcare too will fall.
So I mean, this is an interesting point, right? Because I mentioned Amazon and their dislike of unions, and that's going to come through when they as they get more and more into the healthcare sector. If you look at the Biden administration, which is the most pro-union administration we've had for, I don't know, since the war, God knows, a long time, right? Since certainly this century and maybe my lifetime. It's incredible that in the energy bill, like I said, if you want to, there's a lot of things you're going to have to do to get the subsidies for the energy side of the bill, not the healthcare side. Including if you want you to be offering the $7,500 a car subsidy, tax credit, that you want to get that for your cars. Most of the car has to be now made in America with union labor and apprenticeships. There's a bunch of industrial policy being baked into that. And I think the same thing is true with a lot of the other stuff going on in the energy side of the bill. I don't know what that's going to do to the Teslas of the world, or whether there are some people who don't like unions, the Musks and the Bezoses among them, and whether they're going to come to some sort of compromise around this, or whether we all end up back in the 1980s, GM sort of feeding off itself, or the dance to excessive profit and inefficiency that Michael talked about. But it does seem to me that we've got a choice in healthcare, which we're a long way away from figuring out, which is, can we provide a more consumer patient-friendly experience so you can actually get in and see people, and can we combine that with sort of increased both professionalism, but also a better lifestyle and a better work life for the clinicians and the physicians. And there are some people who are getting towards that now. So I'm a born medical member, as many of you know. They make about, if you break down how they make their money, but ignoring the IORA part, but on the fee-for-service sort of commercial primary care part that I'm in, they make a bunch of it from membership fees. They make a bunch of it from charging people service, and they make a bunch of it from deals with and payments from systems they're referring to that they've allied with these big health systems in different parts of the country. But if you were to push that a little bit more, and they enable same-day appointments, very ready access to.
Is there continuity, Matthew? You say
there isn't. They don't have great continuity once you get past the primary care part. But to be honest with you,
but you can see the same primary. Can you see the same?
Yeah, yes, you see the same primary care doctor, my doctor as well. But to be honest with you, their population is not full of chronically ill people who need to go and see all the specialists. Right? Now, when they're quite like IORA, they change that, and who knows how that will play out, because they do some selection. But if you look at some of the whatever you want to call it, concierge medicine players who do charge a bit more money. I'm not talking the 20,000, 50,000 a year for Jordan Schlane private practice folks. I'm talking to people who charge 2,000 to 3,000 a year. And there are plenty of people who can afford that and pay that. If you talk to those people who tend to be primary care doctors who've turned their back on working with big systems and don't want to do that, and there's a little sort of rebel alliance of them. I don't know if it's true or not, but they all claim that because of they cut their panels down to 500 instead of a couple of thousand. They claim they can save 20 to 30% overall on the cost of care, including their extra fee they get paid because they look after their people better and they coordinate care better and they don't let stupid stuff end up, stupid invents end up in the ER and hospital admissions and that kind of stuff. If you believe all that, which is a bit of a leap, but if you do believe all that, I've said for years, we could easily afford to give everybody in the country, a $3,000 to $5,000 a year sort of voucher, and to go and have a direct primary care doctor, because Medicare, Medicaid, everyone else could pay for that, and have them on a panel of 500 people. The only problem is we'd have to find, I think the numbers work out with 600,000 or 700,000 primary care doctors, and right now we have 200,000, whatever the number is, and 600,000 or 700,000 specialists. So, having said that, those primary care doctors in that system would all make $500,000 a year each, and they would be fine. So, but that would involve completely flipping the way we structure our system, which, and I would say to Mike, yes, primary care is in these integrated delivery networks is bad, but the goal of primary care in those integrated delivery networks is not to deliver freedom from fear and worry or deliver primary care. The goal is to find the expensive stuff to shuffle into the system to make where they make their money. And the primary care experience doesn't have to matter so much. So I would love to see a change like that and reemphasize, old-fashioned primary care, but done in a 21st century way with technology and with support and with patient self-service where it's appropriate and with at-home care and monitoring and all that kind of great stuff. But
so
I don't know how we get there.
A comment on the concierge model, though. I mean, I don't doubt that it's great for people who are able to afford it. So it's going to be your more affluent, and for physicians who are seeking a different lifestyle. But I don't see it as being scalable, and it's probably adding to the general decline of the health system. It's taking a pool of doctors who are highly desirable and effectively eliminating them from being able to see the general population because they're off dealing with affluent folks.
I'm with you. You'd have to make everyone affluent, right? And the way to make them affluent is you do that by you redistribute money within the healthcare system and the taxpayer part of it. And by the way, it is all tax paid. I mean, I know there's employer contributions, but between the Medicare, Medicaid, all the other government programs, and the massive tax subsidy that people buying private insurance from their employers get, there's a tax-based system. We should be able to move it around if we wanted to. I'm not sure that's politically easy, but we should be able to do it.
Matthew, what we need to do is require all primary care doctors who are now working for private equity companies or Amazon or any of those people like Dr. Lyle and others, because their medical school tuition was subsidized by the taxpayer, they have to see patients a few days a week. Every doctor who's on Wall Street has to also see patients. I once talked to a PR firm that had 3 primary care physicians working for it. That was more than Mercer had in its healthcare practice. Now, by the way, my father said,
hang on, do you want those doctors to be seeing patients, or do they get out of it for a
well, that's
coming back to reality.
Mike, you're the only person here who's about to be sent back into the clinic by Michael, so watch out.
I want to just simply emphasize that, first of all, I don't believe concierge is the answer. And second of all, I don't believe in turning back the clock. But when my oldest boy told me that the primary care practice, which is a sophisticated primary care practice, that's the part of the Brown Family Practice Program, had established their day-to-day care on a first-come, first-served basis as need. And that they had eliminated all of these expensive ploys, both mechanical, telephonic, computer, to basically prevent you from being seen, which is not inexpensive. It costs a lot to frustrate Americans to the degree that we are currently
But it's very effective.
frustrating Americans. It's expensive, and it has a huge man count to support that, let alone the systems and licensing fees. So when I heard that they had canned all that, and that if you needed to see a doctor, you didn't worry about, wait a minute, Dr. Phil is my doctor, because the team was committed to making sure you're seen. They had coverage, and everybody was there doing their work, right? That you would come in and you wouldn't even pick up the phone to try to penetrate a telephone tree, because it wasn't a telephone tree anymore. That just said to me, man, we've gone way astray. We've been sold a bill of goods. We under the mantra of, we're going to organize this. We're going to make it efficient. We're going to hire 10, schedulers for every one doctor. And we're going to buy the latest and the greatest computer system. And it takes the person who's most experienced a minute even to get into the right spot to see if the doctor can see you 5 months from now. I just said to myself, man, I think this is what we have structurally created, and it certainly isn't less expensive. And I can tell you for sure, it sucks for the patient.
Well, I don't think we've really reimagined primary care generally. I mean, start with medical school. Is the medical school really set up to do primary care? We educate all physicians sort of the same until they get into residency and so on. Our medical education is much longer than other countries. In a world of NPs, PAs, AI, whatever, what should primary care do and who should do it? We're just sort of trying to stick the existing square pegs into what's becoming a round hole, and being surprised that it's not working. Well, we need to figure out, well, the holes are not matching. Let's not try to force what we've got into that. Let's try to, maybe we need to change what primary care is to begin with.
I'd argue that most other countries, they don't force people to go through 4 years of undergrad before they get them into medical school in the first place. And obviously we have the issue here, goes without saying, that by the time you get out of medical school and you're hundreds of thousands of dollars in debt, then the attractiveness of going on doing, diagnostic radiology at $600,000 a year or $500,000 a year compared to pediatrics at 120 or whatever the numbers are. I know they're not quite that extreme, but they are extreme. Obviously leads people to choices, and then we don't restrict specialty places, although we do restrict residency places overall compared to the number of doctors we train. But having said all that, we're not getting away from that system immediately. My idea of, let's get 700,000 primary care doctors to do, concierge style, forward or MD-VIP style medicine and hope that brings down the overall system costs is a hell of a leap. But there is going to be more and more use of, as you mentioned, Kim, whether it's AI and chatbots and technology to deal with minor issues, and then all kinds of extenders to help people get through the system. That's got to grow. The primary care function has got to grow bigger. And I think part of what you're seeing, it's had its booms and its busts, but this concept of navigation, which is essentially what all primary care groups are trying to do, or is being done by navigation companies like Included Health or Accolade, is essentially, can we answer Mike's problem? Can we get you to see a doctor? And maybe there are, when you need one, and maybe there are other approaches. Maybe it's you declare an open schedule, you give up appointments, and you do what Brown Family Care is doing, or whatever. But it seems to me that we're going to come up with some massive other solutions for the lack of access to primary care, and maybe one of them is going to be Walgreens. Walgreens, they deal with WebMD and WebMD with VillageMD. Walgreens is still going to be growing its thing. CVS is talking about expanding. They were looking at buying One Medical, and they're clearly talking about expanding. Do we make it where people go anyway? Maybe that's the way that a lot of primary care gets done. So we're going to come up with some solution. I don't think this cures our overall problem, which has always not been that, is that primary care is this ugly stepchild, ugly stepsister. It's the Cinderella. And hang on, it's the Cinderella or the ugly stepsister? I got that wrong. It's got to be, you're one or the other, right? It's the Cinderella, right? It gets no respect. And all the money, all the prestige, and all the high spending is in the big white building, or been stripped out of the big white building by entrepreneurial private equity backed doctors, and they're the ones who make all the money, and they're the ones who go down the supply chain of, the high priced devices and the high priced drugs and all the other stuff. And that's where it's been ever since I've been here, and probably since the 70s, that's been where the money's been in American healthcare. And we have not figured out how to change that and to do, primary style care, population health, the way that allegedly they do it in the UK or New Zealand or Holland or Norway or wherever, and that's why we spend so much more money.
Matthew, but we talk about access to primary care. What Mike said, and I've seen in healthcare systems here as well, they think they are giving you access to primary care, right? But what they're not doing is giving you access to your own doctor with continuity. So in the group practice that I go to, when the system that owns it shuts down any sort of walk-in hours, so you'll go to their urgent care center, right? In their mind, they're being efficient. You have access to primary care, right? Or that PA or something. And so what's happened is that they are giving you access on their terms, on their efficiency terms, on their profitability terms, as opposed to on a more human scale that says, what, even though we can't measure it immediately, the fact that you saw your own doctor or someone in that same group has clinical value that we shouldn't strip away. And that's what happens when the decisions are being made by multi-billion-dollar corporations that value the bottom line, even while they're supposedly nonprofit. But that's what's happening. It's corporate medicine.
Well, the other side of this is that, there is a price to be paid for creating such a level of frustration within a society. Maybe I'm the only one, but it is not a stretch for me to believe that one of the reasons why America is so angry and so violent and so upset at the moment is in part related to the fact that they don't feel secure. They don't feel cared for. And it's not simply that their medical problems are put on postponement, they can't afford it, or they can't get to see the person who might help them. But they don't have access to somebody who's going to touch them and who's going to calm them down. And I think overall, that has a societal impact. Now, in America, you'd never know that because we never asked the basic question, how do we make this nation healthy and secure? We never said it. We never explored it. We never thought about structuring up for a healthy society. We think we sort of did when we said we need more public health, but that's not the same question. The question is, if you're going to have a safe and secure society, it is going to be more peaceful. It is going to feel less in need of having guns. It is going to not be on the verge of blowing a gasket every 2 minutes. So I just feel like we kind of reached that boiling point, and whatever we thought we were doing in structuring this thing up to be more efficient, to finally get the costs under control and all that, it hasn't worked. It's going in the opposite direction as far as I can see.
I mean, I'd agree, but there's a lot of different things in that lack of security, right? There's a lot of stuff with employment. There's a lot of stuff around access to, college, access to housing and the cost of housing. And there's a bunch of indicators which clearly made things go. And then,
but I'd argue that all of that, Matthew, are things that would be discussed if the basic question, how are we going to make this nation healthy, had ever been put in front of a governance group. That's my point.
Fair enough. All right, we have come to the end of another perfectly good hour, which we spent discussing primary care and all the ills of American healthcare and everything else. So let's go real quick, go around just 20 seconds each as to what you're expecting, what you're looking at, what you're expecting, and what's going to happen next. I'll start with you, Michael.
I think that what we're seeing in the so-called dog days of summer is behind the scenes, all the machinery is sort of cranking and adjusting. So all the investors that thought there was quick money in anything that had the words tech and healthcare inside of it are saying, well, wait a second, maybe they're not all winners all the time. The health systems that are losing some money are taking a look at their operations. And of course, all the people who are selling to them are looking. And our friends at the drug companies are seeing at least one decimal point to the right, perhaps shift a little bit. So I think with the legislation, we're seeing a period of adjustment. And we don't know how folks will adjust after some of the easy good times are coming to an end, and how they're anticipating this winter with possible more public health problems coming. So this is an important time. It's a period of anticipation, but whether we do a good job of anticipation to prepare ourselves for the winter of discontent remains to be seen.
Vince.
While the issue's been mostly off folks' radar screens, the New York Times continues to report daily about 100,000 COVID infections. We know that that's vastly underreported, and 400 or 500 deaths. What I'm looking for, I would expect soon we will see results of ongoing clinical trials. I'm curious to see whether the vaccines that are being developed and hopefully will be available this fall are going to be effective against some of these variants. This thing's not over yet.
Damn good question. I'm trying to figure out, I'm 5 months post having COVID. I'm trying to figure out whether I should wait for that new variant vaccine or whether I should get it done now. I don't know. Mike, quick closing comment.
Yeah, I agree with Vince. I'm teaching a course this fall on epidemics, and this is one of the texts that I've been looking at, Epidemics and Society by Frank Snowden, a historian. And it is interesting when you look back at epidemics of the past, you begin to realize that they are the real shapers of societies and the way people in the future interact with each other. The quote that I read this morning was that history is about reflecting on the past and science is about reflecting on the future. But that science often attacks the history of the past. So I sort of am focused on Paul and those people who were taking care of him before he died, and the fact that they're really good people and we need to do right by them. So I think we need to focus on what is required to support these people.
Yeah, actually, just on the pandemic part, I was with these Australians last night, and the people in Melbourne had a 6-month lockdown. They could only go out 1 hour a day, and it was really strictly enforced. And they were basically, these were government officials. They were not necessarily in health, but they were government employees, and they would. A couple of them said, it was just so much that by the end of it, nobody could handle anymore. And I can't imagine how bad that could have been, because even though we had lockdowns here, they were never enforced like that. All right, Kim.
3 sort of unrelated stories are troubling me. One is what's happening at Boston Children's, where a bunch of false stories about what they're doing on transgender care has led to online abuse, death threats to their staff, and so on. The second is a 16-year-old girl in Florida who was ruled by a court not to be mature enough to have an abortion, so she has to have the child, as though that requires less maturity. And then there's a case, I believe it's in Wyoming, where a mother and her daughter are being prosecuted for doing the Plan B.
Nebraska.
It's Nebraska, yes.
And using the
quite a late pregnancy, actually.
Using their private Facebook messages to prosecute them. So I just feel like the wrong people are getting involved in our healthcare for the wrong reasons, and no good is going to come of that.
I would not disagree, and there are more people who need all of those. People clearly need support from care and warriors, Mike would say. All right, you've listened to, this is the end of the THCB gang for August the 18th. I'm Matthew Holt, your host. Thank you very much for listening. My guests today were Mike Magee from Connecticut, Kim Bellard from the baking Central Plains of Cincinnati, Vince Kuraitis from the cool mountains of Idaho, where it's probably 95 degrees up there, and Michael Millenson from the hot city streets of Chicago. Well, now the Tony suburbs of north of Chicago, where the cool breeze off to Michigan is keeping him under control, down probably in the low 90s, I would guess, today. We'll be back in a week, but I'll have another group of my regulars with THCB gang. Many thanks to all of you for watching or listening on the podcast, and we will see you in a week's time.